Hey, how are you?
Good, how are you?
My name is Jessica Mitchell and I'm with Columbus State University, and today we're going to talk about how to prevent patient hypothermia in the perioperative area. Preventing patient hypothermia is imperative for positive surgical outcomes, patient safety, and increased patient satisfaction. An estimated 50 to 90% of patients experience unplanned surgical hypothermia. This presentation will provide information to help minimize patients' risk for hypothermia and how to prevent it. What is perioperative hypothermia? It is described as a core body temperature below 36 degrees Celsius. Prevention of unplanned perioperative hypothermia is a national priority and an issue for hospitals nationwide. Perioperative hypothermia has adverse effects that span from patient discomfort to increased morbidity. Causes of unplanned hypothermia: cold room temperatures, cold IV and irrigation fluids, skin and wound exposure, especially in an orthopedic OR with all the different positionings and beds and exposures of the different extremities. Patient risk factors. Some risk factors include their BMI, their age, an infant or elderly person, and their nutrition. Effects from anesthesia, blood and fluid loss, the patient's body type, and not pre-warming the patient in the outpatient area. Also, if a patient's systolic blood pressure is less than 140, they are more likely to develop hypothermia. Some effects of perioperative hypothermia: patient satisfaction. We all know that that is very important. A lot of these, you win awards and get reimbursed according to how satisfied your patients are. And if they're freezing to death, then they're definitely not going to be satisfied with their whole experience. Increased risk for infection. An infection rate is increased because of vasoconstriction, which prevents the flow of nutrients and oxygen to the compromised tissue. When the oxygen is limited, neutrophils, which is the first line of defense, they're not able to perform properly, which can increase the infection rate. Impaired wound healing and pressure ulcers, which increase the hospital stay. Increased bleeding and increased need for blood transfusions. 3 times the risk for cardiac complications. If body temperatures are below 86 degrees, it can produce aflutter and AFib, and VTAC and VFib result from temperatures below 82 degrees. And also a prolonged recovery time for the anesthesia medications to metabolize through the body. How to prevent perioperative hypothermia. Pre-op nurses should assess surgical patients for risks that would contribute to perioperative hypothermia and implement a plan. The outpatient nurses should get a baseline temperature and record it. Pre-warm the patient at least 10 minutes prior to surgery using forced air, like with a bear hugger, the gowns you can wear and hook the bear hugger to. 10 minutes is minimal, but it would be best if you could do it longer. Use warm blankets.
You guys having a meeting? Okay, thank you.
It's okay. Use warm blankets. Now normally we grab 3, 4 to keep them warm, but actually evidence says any more than 2, it does not help the patient. 1 or 2 reduces heat loss for the patient. Provide passive warming measures. Special caps, socks that we use, those are passive warming measures. So what we really need to do is turn up the heat. Okay. To continue talking about how to prevent it, warming IV fluids to 37 degrees Celsius using warming cabinets. Fluids must be warmed for over 8 hours to achieve temperature of a warming cabinet. Use fluid warmers. Use of forced air with disposable blankets and gowns, which you guys are familiar with. You can also use a conductive warming pad that goes on top of the operating room table. Maintaining ambient room temperature from 20 to 25 degrees Celsius. Now that is 68 to 77 degrees Fahrenheit. We all wish that the doctors would let us do that, so maybe we could come together and show them the research as to why we need the room at this temperature. The NICE guidelines, NICE is the National Institute for Health and Clinical Experience. They suggest that all fluid and blood products should be warmed to 37 degrees Celsius. Here are some examples of some different warming devices. Here's an IV fluid warmer, a bear hugger unit that you can connect to a blanket or a bear hugger gown, a warming cabinet, and this one's really cool, especially in the OR because we irrigate all the patient knees, hips, shoulders. The 3,000 cc bag connects to a machine which warms the fluid as it's going into the patient to the required degrees it's supposed to be. And then here's the picture of the blanket. According to the Surgical Care Improvement Project, all surgical patients should be actively warmed during surgery and have at least one recorded body temperature of 96.8 degrees Fahrenheit or higher within 30 minutes prior to the end of anesthesia. Improve patient outcomes, increase patient satisfaction, shorter hospital stay, reduce hospital cost, reduction of infection rates, decrease in pressure ulcers, maintaining skin integrity, and decrease blood loss and transfusion rates. Shorter time in the recovery room, and a decrease in cardiac complications. Nursing informatics. I'm not sure if you're familiar with that. We've all been out of school for a while, so this is pretty new. Nursing informatics is the science and practice that integrates nursing, its information and knowledge, with management of information and communication technologies to promote the health of people, families, and communities worldwide. Nursing informatics, the information we put when we chart. They can take that information and put it together to do research on temperatures, on skin integrity, different things. So you can take that information and do a quality improvement project according to what you've put in the computer. Evidence-based practice. This is really coming about. People are starting to turn this, hospitals are starting that are just solely based on evidence-based practice. Evidence-based practice provides nurses with a method to use critically appraised and scientifically proven evidence for delivering quality health care to a specific population. Quality improvement. With the use of nursing informatics and evidence-based practice, change can be made in your facility. Document patient body temperature. We all know document. Something happens, document it. That's the only way that we're going to prevent, make things better or cover ourselves if something happens. Gather all documentation supporting negative outcomes from patient perioperative hypothermia. Provide a proposal with the problems, need for change, and benefits for the patient and the hospital. Meet with management to discuss implementing a quality improvement project to help prevent perioperative hypothermia. To make an effort in reducing cost, complications, and patient satisfaction, it is important to maintain patient normothermia throughout the patient's course of treatment. You guys have any questions? And there's my reference page. Thank you.